Thank you for the folks who were able to join us today, and those who may be watching after or looking through the materials. If you have any questions during or after the presentation, there'll be an opportunity to ask questions during. You can pop questions into the chat. If you want to, if something comes up afterwards and you want to reach out to me, please feel free to do so. You can reach me by email or by phone, and I'm happy to do any follow-up. So today, a very broad topic, and over the next several months, what I'll probably be doing is talking about more detail in this area. So I wanted to start broadly with healthcare payers and reimbursement, provide some background information, and then we'll go on and talk about more details about some of these individual systems, the auditing and appeals process in the systems, and generally we're going to talk about and focus a lot on payment systems and how individuals in the business of healthcare get paid and keep their earnings and get paid for what the work and services are that they're providing. That seems to be a big issue that we're seeing a lot of clients who are dealing with rejected claims that are requiring pre-approval audits, overzealous auditors. That's been an ongoing issue for a while. And so we're going to try and give you some information that'll help arm you to better prepare you for dealing with some of these conundrums. A little agenda here on the screen of the information that we're going to cover today. After we get done with a little introduction, some background, we'll talk about different payment delivery systems and the private and public payers who provide those systems, and some alternative payment models at the end. This graphic here provides an overview of where the dollars come from for healthcare expenditures. This is based on information provided from CMS in 2021. I've been watching for updated information, but what you see here is that most of the health expenditure, which represents by some estimates upwards of 18 to 20% of our GDP, so the largest expenditure, even exceeding military, most of that is coming from the federal government. After federal government, a little bit surprising, individual households. This is based on co-payments and co-insurance and private cash pay systems. So households, individuals represent the second largest segment. After that, private companies, often through employer-provided health plans, state and local governments, and another private revenues for healthcare. This number is expected to continue to increase up to just approaching 20% of GDP by 2031. As the population continues to grow, the healthcare expenses continues to grow and continues to age. The healthcare expenses are expected to go up. However, what's interesting is Medicare, along with other expenses, are expected to increase. Medicaid, which is another federal program provided in conjunction with the states. It's a federal, I like to refer to it as a state and federal partnership. Medicaid is believed to have likely reached its peak somewhere around 2022. So we probably just finished and came out of the peak of Medicaid, while everything else will steadily decline, or steadily increase, and Medicaid will steadily decline. Talking about some of the terms that we'll refer to today. Healthcare reimbursement. This is just the money that the provider receives for delivering the services to the patient. Oftentimes, this money comes from a third-party payer. You'll see we'll use that phrase a lot as we're talking about these issues. The payer just refers to the insurance company, whether it's a public entity such as Medicare or Medicaid, TRICARE, a private company through a private insurance company, or some managed care plan, perhaps sponsored by a state. They're the payer that will provide payment to the healthcare provider. And the beneficiaries, or the patients under this system, will see the terms member or enrollee. You'll also sometimes see beneficiary. This is generally referring to the people who are a part of the plan eligible to receive healthcare benefits and services. Most of the services are provided on a reimbursement basis, but there are some instances where providers, again, they'll either work on a cash pay. We'll see some alternative payment models where maybe there's payment in advance, concierge medicine type systems, or where certain pre-approvals are required. So either payment or pre-approval of the payment is required in order for a beneficiary or patient to receive care. It's also possible, note that patients could be operating or working within more than one healthcare system, and theoretically the health plans will coordinate with each other to determine the appropriate liability for each plan. An example of this might be where someone has Medicare and has a high deductible plan that they use to help pay for co-insurance or additional expenses not covered by Medicare. And we'll talk about that a little bit later as well. So historically, our system of healthcare in the U.S. has been based on a fee-for-service system. That's FFS. This is essentially where services are unbundled. And CMS has tried to shift away from the fee-for-service model, essentially believing that it is not the most efficient delivery mechanism for healthcare. And so in an effort to, and we'll hear this phrase a lot, improve quality of care, improve results, and improve cost efficiencies or lower costs of the care, Medicare, the CMS has implemented, tried to implement anyway, essentially alternative payment models, and some of these are also being implemented on a private basis. The most recognized of these is the, we're going to talk about with ACOs under the Medicare Shared Savings Plan, and I'm going to perhaps do a whole presentation on that in a later seminar. But as you see on the slide here, we point out the inpatient prospective payment systems. This is where CMS has started to veer away from the fee-for-service model and operate on a more prospective basis through alternative plans with inpatient and outpatient providers. These systems in turn led states to start exploring managed care plans with their Medicaid system. Here in Florida, has Medicaid that's administered through the Agency for Healthcare Administration, and those plans are generally managed care plans, which we'll talk about again in a little bit more detail. On fee-for-service, again, as I mentioned, this is the traditional healthcare model for payment, and this is where the provider is paid for each, essentially each option off of the menu. Payments are unbundled, so you have a separate payment that's due for each procedure, test, goods that the patient receives, etc. In this type of system, generally the enrollee or the beneficiary could choose a provider, and there's very few restrictions on what provider and what services the patient receives as long as they're covered by the plan. There's typically an arrangement for in-network providers to provide discounted services, and then if you go out of network, you're often as a enrollee, and most people know this, if you go out of network for services, you're going to pay more for those services. That's because generally the in-network providers have agreed to a contracted rate with the plan. Managed care has its origins in plans where individuals or groups would pay for a set of services. Essentially, they're paying, the theory is that they're paying for results. So an analogy to this might be in some circumstances where an individual could prepay for all of their care to deal with a pregnancy, for all of the services required in a pregnancy to have a baby. Some hospital systems or some healthcare systems would allow individuals to negotiate one set price that they would pay for the entire care. This model, again, is based on the idea that if we allow the providers and the payers and the providers to coordinate in a way to best provide services for the best results and in the most efficient manner, the costs will be reduced, and theoretically the quality of care will be improved. A lot of people might debate the results of that, but what's really tough to debate, and today isn't really the opportunity to talk about this or the time to talk about it, but when you look at care in the United States, as much as the United States spends on healthcare compared to other countries, and the results we have with respect to how healthy the population is, it doesn't take too long to realize that there are some inefficiencies and some drops in the system. Some of the problems are also created by the fact that people providing the services But you have three distinct groups of individuals, and this has a lot to do with healthcare regulation when we talk about fraud and abuse and overpayments and so forth. Is that your individual who's going for care, your patient, is often not the person primarily paying for the services. There's a third party paying for those services. Sometimes it's private, sometimes it's federal government, and then you have another person who's providing those services, and they're providing services and making recommendations to the patient, and neither one of those folks is making those determinations with the idea, generally speaking, that they're the ones responsible for the financial aspect of it. The provider is getting paid by a third party, and so the third parties, of course, are motivated to assure that the services are not overutilized or not wasted in order to control costs, etc. So how to manage care plans, control costs and services. Some of the ways are listed here on the screen. They may contract to create a closed provider network to provide in-network care, negotiate with those providers to provide services at a different rate, or in bundled rates. For instance, to pay a primary care provider a set fee to provide certain services to individuals in the plan. The plan may require that a patient or beneficiary in the plan designate a primary care provider, who will then be the first point of contact to make the determination whether additional care or specialty care is needed, and then require referrals or authorizations for certain specialists. The managed care plan engages in a constant process of utilization review and management, where the plan is looking at the costs and trying to find out where there's waste in the system. Essentially, where is the fat in the system that can be cut, and where can the efficiencies be improved. The plan may have an approved formulary, which is a list of approved prescription drugs, and other defined services may be provided in packages under certain managed care plans. And we'll talk about the different types of managed care plans next. Most common of these are HMOs, PPOs, point of service plans, and high deductible health plans. We'll touch on each of those individually here. Under an HMO, this is where services are provided, organized in one specific geographic area generally, and there's coverage for a defined set of healthcare services for the enrolled population in that area. The different HMO models include a group model, individual practice association models, network models, which may be provided by multi-specialty groups or a primary care group practice, staff models, and direct care models. A preferred provider organization provides a little bit more flexibility and choice for the enrollee in the plan. Under the preferred provider network, the enrollee generally designates a primary care provider, but is not required to get pre-approval from that provider to visit other providers in the network. Like the HMO, there's in-network and out-of-network, and the coverage for in-network care is generally going to be less expensive because of the negotiated rates with the providers. But oftentimes, if an enrollee goes outside into the out-of-network care, they're going to pay higher deductibles, higher co-insurance, and they may have higher charges overall that aren't covered by the plan because the plan has not negotiated a reduced contract rate with those specific providers. Under a point of service plan, this is sort of a hybrid model between the HMO and the PPO, and similar to an HMO, the enrollee may designate a primary care provider and obtain referrals from the provider for services, specialty services that receive from other providers. But like a PPO, the plan covers in-network and out-of-network care, where the enrollees have higher costs for going out-of-network. These plans, similar to other managed care plans, may require deductibles. Usually there's deductibles, there's premiums, there's co-payments, co-insurance, that all may be paid by the individual. And this goes into when we were talking in the beginning of the presentation on household costs. A lot of these household costs aren't necessarily individuals paying for all the services themselves. It's oftentimes these co-insurance and other types of costs that the individuals have to pay alongside of the insurance company. One question that comes up sometimes, I've had people ask, is, well, what happens if the provider wants to waive those costs, wants to waive a co-insurance or a deductible, a copayment? And in Florida, there's an issue with that with respect to just general fraud and abuse laws and the kickback statute. And the reason for that is that the provider is not supposed to provide a financial incentive for the beneficiaries to use their services. And in Florida, it could potentially violate the insurance statutes, which make it unlawful as a general rule for a healthcare provider to waive the copayment of an insured. So if anybody's thinking, if you've ever run into that situation, and this is where it sort of gets into a little bit of a gray area as well, is a question that I've gotten from providers as well. If we didn't collect the copayment from the patient or from the beneficiary, we've been now reimbursed by the insurance company. How much effort do we have to put into to collecting the copayment? And that's the answer to that question is that you have to make a good faith effort. It can't be this can't be a wink, wink, nod, nod thing where we don't collect the copayment from the patient, provide the services, get paid by the third-party payer, send a letter and ask for the patient to pay their share of the services, and then after that we don't pursue any further collection activity. You have to make a good faith effort. It can't be a pattern in practice, and the reason for that is that the payers, that the policy is that the payers don't want patients to overutilize care, and so they want the patients to essentially have some financial skin in the game in order to go receive services. Otherwise, the thought is that patients will just constantly go out and seek services if they don't have to pay for anything, and they'll drive up healthcare costs. They'll also have less vested interest in their own personal health and try to make sure that they don't need to utilize the services as often. And a high deductible health plan, this is used in conjunction with a health savings account. And the trade-off here is that you get to put pre-tax dollars into an account that then can be used for certain expenses under a health plan. And the health plan often has higher out-of-pocket costs, but you're paying with pre-tax dollars. This can be it can be combined with a health plan that's an HMO or a PPO plan. You'll also see where certain high deductible health plans can be combined with some of the federal payment programs, where some of those dollars can be used to help offset some of the out-of-pocket costs. All right, so skip back there. So that's a quick overview of the payment systems. Now we're going to talk about private payers, and then next we'll go into a discussion on public payers. So private payers, these are private health insurance companies. The private payers will offer a variety of healthcare plans. Most of these are generally going to be employer-based plans, where the employer is paying a part or all of the cost of the plan, the premiums for the plan, or there's an employee contribution that may come out of the employee's payroll, or what some employers will do is they'll provide maybe coverage for the employee, but then the employee's family members can be added in an out-of-pocket cost for the employee, or the employer will provide a certain threshold of contribution, and after that the employee has to pay the rest. So most people who have worked full-time in a job and have coverage through their employer are familiar with these types of plans, even if they don't realize exactly what it is. These are provided by private health insurance companies that then provide different types of plans that the employer selects. The employer can select one or more of these plans, and the employee then gets to select from maybe an HMO or a PPO or some other type of plan that the employer provides. In our office, we generally try to make a couple different plans available for the employees so they can select what they think fits best for their needs of themselves and their family. Commercial plans, this gets into a little bit of ERISA issues, and I've had this issue come up with clients who have wanted to essentially either provide private fund a plan or provide plans through alternative, not through traditional insurance companies, but provide alternative coverage for their employees. And the term here, and this is a term that's out of the federal regulations, is commercial plans must cover certain essential health benefits. I haven't listed out what those essential health benefits are here, but they are listed in the statute, and generally they include emergency services, hospitalization, lab services, mental health and substance abuse, pediatric, pregnancy and maternity, prescription drug plans, preventative care and wellness, and rehabilitation services. The plans can provide additional benefits, but in order for a plan to qualify as a plan that the employer can offer to its employees and meet all the regulatory requirements, the plan must offer these essential health benefits. So any private insurance company that the employer contracts with is generally going to offer those benefits, and some will offer additional benefits as well. These plans are regulated by the states, except to the extent they're preempted by ERISA. But having looked at these again on behalf of for some clients, I do know that you need to meet the essential health benefits requirements in order for the plan to qualify, and then the states may have additional qualifications over and above that. So as I mentioned, with employer-based coverage, it's often purchased by the employer and offered to the employees and their dependents. And the employer generally subsidizes that coverage through the full or partial payment of premiums, with the balance deducted out of payroll. Also, there's COBRA coverage, which is coverage that's provided to certain employees if they're covered under a plan and then they leave employment. In some circumstances, the company may be required to offer that service or that coverage to employees so that they don't have a situation where they're dropped from coverage. Where that becomes really important is an employee who's got an ongoing health issue that may have had difficulty getting additional coverage, although that's become less of an issue with the ACA, I suppose. Or, for instance, maybe somebody who's going in the middle of either some type of event like cancer treatment, or someone who's pregnant, and they lose their job midway through. They have the right to continue that coverage until for a certain period of time after their employment. So the plans that the employers provide, these can be either fully funded, or they can be, fully insured or self-funded. And we'll talk about what those mean here. The fully insured plans, this is where the employer goes to a insurance company and purchases the health coverage, and then that coverage must meet the state and federal requirements that we talked about. In these plans, the insurer is taking on the financial risk. So this is a term that we're going to hear more and more often as we start diving deeper into some of these issues today and in other webinars. And who bears the financial risk, or where is that financial risk? Who's taking on more of the risk? It will change from plan to plan. On self-funded plans, the employer is paying for the healthcare services that are used by the employees by establishing a dedicated fund, which again must provide the essential health benefits that we talked about, plus can provide additional services. The employer and the employee pay, so the employer funds the plan, they do contributions from the employee, and then that plan that is funded by the employer is now taking on the financial risk. There are some large companies that do self-funded plans, not as common with small companies, and you see it sometimes in groups or unionized type situations. So in addition, the other type of private payer, in addition to those from commercial insurance companies that provide plans oftentimes through the employers, are individuals who can get individual coverage. Again, if they don't get it through the employer, they can get it through private insurance companies. They can pay cash, or they can get plans through the exchange that's created pursuant to the Affordable Care Act. Again, like the employer plans, these plans, they generally have a premium payment that's required by the individual getting the coverage, and then the individual likely has some level of co-payment or co-insurance. And all of these plans will generally have a cap on out-of-pocket expenses for the individual, so the individual is financially decimated by some type of catastrophic event. So in all of these circumstances, the individual or the patient is paying, but they're not taking on full financial risk in most circumstances. Under the ACA, and I think this number is still accurate, generally the income threshold is 400% of whatever the federal poverty level number is. And if your income is under 400% of the federal poverty level, then you can be eligible for some subsidy under the ACA. All right, we'll move on now. This is a much broader topic. I'll look at time here. Talking about public payers in the U.S. Of course, the largest of these are the federal government with the Center for Medicare and Medicaid Services, which oversees Medicare and Medicaid. Also, the Department of Defense, which provides coverage in two different forms for military and veterans, and then some other organizations through federal and state governments that we'll talk about a little bit in detail now. First, and the largest among these, of course, is Medicare. Medicare is the federal program that was created through the Social Security Act. Generally covers individuals who are age 65 or older, regardless of their income, medical history, or health status, as long as they have enough credits paid into the Medicare system and their permanent residents are U.S. and they've lived in the country more than 5 years. Medicare also provides certain coverage for individuals who are under age 65 if they have a qualifying condition or event. And if this is less common than those who are on the older population, but just understand that there is additional coverage available under Medicare for those individuals who qualify. Medicare has 4 parts. Part A and B has traditionally been called the original Medicare or traditional Medicare. A covers inpatient care and B generally covers outpatient care. And then we have Part C, where this is coverage that's provided. It's Medicare coverage provided by private health plans that then contract with CMS to provide coverage and receive payments, and essentially they administer the program privately, but they've got to still meet certain requirements for CMS to provide those plans under Medicare Part C. And in Part B is the prescription drug coverage. There's other programs under Medicare that we don't come in contact with as often, but these are our all-inclusive care for the elderly. This isn't this is more limited in its offerings. And then the Innovation Center's demonstration projects, we'll touch on those a little bit. The biggest of these is the Part A, Part B. I think it's still the largest in Medicare system. And Medicare Part A, this is inpatient services generally, covers hospital services, hospice. It does require deductibles and co-insurance, but many beneficiaries don't end up paying premiums because of their contributions through payroll taxes throughout their lifetime. That's the FICA tax that comes out of your wages from your employer over the years. The beneficiaries receive this medical summary notice, which advises them of utilization of benefits under the system. And they can also opt for what's called Medigap, which is essentially a supplemental plan that covers the costs of deductibles and co-insurance. So this is again back to the earlier, another example of what I mentioned earlier, where individuals can be enrolled in 2 separate plans that then coordinate with each other. Medicare Part B is available automatically for anybody who's enrolled in Part A, and Part B covers physician services and other types of outpatient care. And additional services that are covered under Part B Also, some drugs and vaccines are provided under Part B, and outpatient services and supplies as well. So Part B services require co-payments and co-insurance as well, except for certain wellness visits that are provided under the plan. And the beneficiaries of Part B, just like in Part A, also have the option to enroll in the Medigap insurance to cover those co-insurance and co-payments for Medicare. Part C is called Medicare Advantage, and this is the plan that is provided through private plan sponsors. They enter into a contract with CMS, and they have to provide certain services to the beneficiaries who sign up. So individuals who don't want to go directly into Medicare have this option to go into the Medicare Advantage plan. And again, similar types of plans is what we see with with the private payer system, the HMOs, PPOs, fee-for-service type plans, and the high deductible medical savings account. They can use this medical savings account plan in connection with the Medicare Advantage plan. Medicare Part B is for drug coverage. And then the programs of all exclusive care for the elderly, the PACE program for under Medicare is a program that provides in-home care for the elderly, who it's an alternative to some folks having to move into a full-time nursing home environment. It's available for individuals who are over 55 and need a level of care equivalent to a nursing home, but allows them to stay in their own home. Also, CMS has created certain demonstration projects. As I mentioned earlier, the most common among these is the Medicare Shared Savings Program that I'll talk about in another seminar. We'll go into detail on what the parameters and the requirements for ACOs are under that program. The other major system administered through CMS, but this one now is federal and state. So the federal government provides dollars to the states and partners with the states and sets a certain threshold requirement of what must be covered under the state Medicaid program, and then the states administer that program. So here in Florida, where I am, the program is administered through AHCA, the Agency for Healthcare Administration. There are certain rules and guidelines that are provided in federal regulations, and then there's state rules for how the plans operate under state law. This is Medicaid is generally available for lower income individuals, and there's federal requirements for certain individuals who must be covered, including children and families and pregnant women. Under Medicaid, the states determine the eligibility and enrollment requirements as long as they match what's required by the federal mandates. The states also can determine specific benefits and services that have to be covered and what the payments are to the providers. There are also the state sets up, and this is important, something else we'll talk about in another seminar, is the appeal process. The appeal process under Medicare is set entirely by federal law. There's a 5-level appeal process. If you're a beneficiary who's seeking payment for services, but also if you're a provider and you have either, if you are under a prepayment review or some type of audit, or if you received a recoupment demand from a CMS contractor, the system that you will run your appeal through is entirely under the federal system. If you are on a Medicaid plan and you are dealing with an audit, in my situation, here in the firm, we will represent providers who are subject to audits, or you might call clawbacks or recoupments, requests or demands from these managed care plans to repay for allegedly overpaid services. In this Medicaid environment, you're going to be looking to 2 places for the requirements on how to deal with these audits. One is what the state statutes and regulations say, and then the second is in the contract with the plan. So each provider that enrolls Every medical provider signs a contract with a specific Medicaid plan, and it can be more than one. These can be privately administered plans for Medicaid in connection with the state, and provider signs a contract, and then dealing with your audits, dealing with your recoupments, all your dispute resolution procedures are set out in that contract and or in the statutes, the state statutes. Medicaid can come in forms of managed care and under fee-for-service plans. And the states, if they want to provide some type of, if they want to provide a plan that doesn't fit exactly into the federal requirements, then they can apply for waivers they can apply to the Secretary of the Health and Human Services for either a program waiver, which is a Section 1915 waiver, or they can apply for a Section 1115 waiver, which is a demonstration waiver that allows the state to try a new pilot program, a new delivery system, essentially an alternative payment model at the state level. Most of what I have dealt with, at least in my practice in representing providers, has been dealing with Medicaid managed care plans. And the managed care options, I've kind of laid some of these out on the slides here. There's a comprehensive risk-based plan where the state contracts with the health provider or the health plan to pay a capitated amount for all the beneficiaries or the enrollees in the plan. There's limited benefit plans, and then there's primary case care management, where the beneficiaries designate the primary care provider, who are then directly paid a management fee by the state for each enrollee or to manage and coordinate care for that beneficiary. So the plan gets money, they sign up their beneficiaries into the plan. The beneficiaries, the number of beneficiaries essentially determines what the plan is paid, and then the plan has the opportunity to try and maximize efficiencies within that plan. I'll check my time here. So this is where this interesting conundrum comes up when we're dealing with, again, payment issues for providers and potential audits. If you look at the Medicaid system in the state of Florida, for instance, if the provider provides services and then the payer is a third party, so the provider provides services to the beneficiaries who are part of the plan based on state law, essentially. The plan is paid by the state to manage the care for these beneficiaries to receive services from the provider. The plan has a vested interest, because it's a private plan, a private company. They have a vested interest in reducing their costs. They can do this by denying payment for services, strictly reading certain requirements for services. They can do it through what I've seen more and more of, which are audits or recoupment demands on providers. And in my experience, what I've seen when folks first come to me and are dealing with these issues is the providers get a letter that says something like, okay, you've been overpaid by $800 or $1,200 or some, not enough to really fight over, not enough to go hire a lawyer and deal with, but that can grow, or they can become more frequent until they're dealing with greater and greater levels of demand that they pay money back, or if they don't pay it back, that it's offset. This is where the plans really have the advantage on the provider. Remember, the provider works on a reimbursement system. Provider provides services and is later reimbursed by the payer for the services they provide to the patient. Now, the provider is relying on those services. The plan has made a recoupment demand based on other services and says you owe us a certain amount of money. Well, in the contract for the plan, it's going to have language that says that the payer can offset future payments due to the provider to cover past overpayments. And that's where this audit issue comes in. Is one, the plan holds all the leverage because they're supposed to continue to pay the provider. But if they determine that the provider's been overpaid and the provider doesn't deal with that head on, this isn't like getting a letter from a private company that says you owe us $1,200 and you ignore it. You say, okay, well, let's see if they sue us. I don't think I owe you, but I'm not going to fight with you. The plan has the ability to offset future payments, and that can financially hurt the provider. until the provider finally says, okay, I've had enough. So what's the provider's leverage here? Well, one, the provider needs to follow the dispute resolution procedures that are in the contract, or at least be familiar with the dispute resolution procedures that are in the contract and they're in the statute. And also note that the plans, when they're doing recoupment demands, they have an obligation, general obligation usually, to educate the provider on not only find errors and make recoupment demands, but also to educate the provider. That'll be in the requirements. It's in the Medicare requirements. That's going to be in the Medicaid requirements. If the plan is too overzealous and they drive out the provider, you get into a situation where the providers withdraw from Medicaid. They're no longer providing services, and that hurts the beneficiaries. So there has to be just the right balance of the plan managing that system, trying to control costs, but without being so overbearing that they limit the number of providers that are available to provide services for their beneficiaries. So that's the push-pull. The plans don't want to drive providers out of the system. They want providers in the system to get more beneficiaries, because ultimately that can be more profitable. And they need to find a good balance in order to do that. So you there know, as a provider, that's where some of your leverage comes from, is that the plan needs providers in the plan. Even though Medicaid is open, any provider that wants to participate, essentially any provider that wants to participate, Medicaid can, the providers do have some leverage. All right, I'll talk about that more. We'll go in the audits in more detail in another webinar. The CHIP program is provided for in conjunction with Medicaid, but it's for children. And then we have certain expansions, again, with the under the CHIP program with Medicaid. I want to talk about some of the other public payers so we don't run short on time. Under military, you've got TRICARE, which provides the uniformed service members and reservists with coverage. There's other eligible enrollees as well. And then you have Veterans Care, which is administered through the Veterans Administration. And then other public programs include Indian Health Service. This one is not as structured as Medicare and Medicaid and TRICARE. There's no defined benefit package, and the budget for this is funded on a year-over-year basis through congressional appropriations. So a little bit more fluidity in the system with the IHS, and then the Federal Employees Health Benefits Program, which applies for employees of the federal governments and certain retirees and surviving spouses. Now, alternative payment models and options. Just touch on these briefly. Again, I'm going to talk a little bit more about some of the most popular of these. But as I mentioned earlier, it's huge out-of-pocket cost in 2021 on healthcare in the U.S. And there's a motivation to try and improve efficiencies and reduce costs. And ways that the federal government is looking at doing this is through alternative payment models. So individuals can use self-pay systems, which can be maybe cash only, where they're paying cash on a cash basis for individual services they receive from health providers. You'll see this with it's similar to concierge payments and direct primary care, which we'll touch on. And then with the direct patient contracting, the physician contracts with patients for some or all of the healthcare services. This is usually done as like a wellness plan. And sometimes you'll see that companies are implementing these plans, or either providing these as an option or implementing these plans for their employees. So that the employees can, the rationale being that if the employees take a more active approach in their health, and the companies pay the smaller cost for some of these plans, for instance, telehealth or wellness visits, things of that nature. If the employees pay for these, or if the company pays for these for the employees, then the employee, that small cost will prevent the employees from having to utilize greater costs in a more expensive system. It'll drive down the health insurance costs for the employee or the employer and the employee, and improve overall efficiency. The two main systems that I mentioned earlier, we have direct primary care, where the direct patient contracts and pays a membership fee with a primary care practice for a defined set of services from that primary care practice. These are all on a cash basis. With being on a cash basis, you're not subject to many of the regulatory restrictions and requirements that affect many healthcare providers. There's strict restrictions on, of course, self-referral and kickback laws that apply for anybody who receives federal payment money from Medicare or Medicaid is the most common. You also, in Florida, there's additional regulatory requirements that apply for companies that receive payments from a third-party payer versus on a cash pay basis. And then finally, you have, as an alternative to the direct primary care, you have concierge medicine, where there's, again, membership fees that can be paid on a monthly or a semi-annual or annual basis. And then that fee is, the theory on concierge medicine is that fee provides for services that usually are separately provided that aren't available under a plan, or they're in addition to an insurance plan. Where providers can get themselves into a little bit of trouble is where they are charging a fee for concierge medicine, and then that fee essentially includes services that are already provided under a plan. Like if a plan provides for annual wellness visits, and then you say, okay, you're gonna pay this concierge fee over and above the regular charges for your coverage. And by paying me this fee, you're going to receive these services. And if one of those services is a wellness visit that's covered under their insurance plan, that can create issues for the provider, essentially a double dip. And with that, sort of burned through a lot of information, very high level overview. If there's any questions, I'll kind of check the chat here. You can certainly pop them into the box. Thank you very much for your attendance today. And if you have any questions that come up after the webinar today, please feel free to reach out to me by, again, email or phone. My email information is on the screen right there.